Yes, hello, it's me again. Yeah, it's possibly good to end the bone sarcoma session with survivorship. However, I think also for survivorship there is a lot of work ahead where we need the patient organizations to lobby for this. Yeah, because we learned that the treatment is hard, and this affects also the survivorship. This is, I think, from ASCO. Survivorship and demographic changes, and this is like correlating things up to 2040, fortunately, because chemo is getting better, treatment schedules are getting better, we will have more and more and more long-term survivors after cancer, and we will also have more and more older people that have survived cancer, and all these people, or most of them, will be not completely healthy people because they may suffer from late effects that we even don't know yet. Yeah, because it's only like in the recent years, I mean, chemotherapy for bone sarcoma, the trials started here in 1980s. So if I would have had a bone sarcoma as a child, I wouldn't stand here, possibly, because I would go to a surgeon and then I would get a relapse next year, and yeah. So it's really very early that it's really now that we can think about what to do with the survivors and what's happening. And this is a quote I like very much. Survivorship starts at the time of diagnosis and lasts throughout the lifespan. And the problem is that the care of survivors is often an afterthought and tends to be fragmentary and is not well integrated into the mainstream of treatment. And models for providing a smart survivor care remain kind of undefined. Yeah, we need possibly like trials or whatever on this. And these are the problems that you might have a lot. And this is a screenshot from a kind of recent New England Journal of Medicine paper, and I put a red arrow here, and I think the most important word is suggested. Site-specific surveillance recommendations for cancer survivors. And suggested means we don't know. Yeah, there are ideas what you have to do for a cancer survivor after a certain treatment in a certain diagnosis, but and you get schedules from your doctors, but most of them are eminence-based and only very little are evidence-based. Yeah, this is what we need to know. It's obviously it's good to have some plan what to do after your treatment, but it's we know very little. So as for me, all I know is that I know nothing. Yeah, we are not in Greece, but it's still okay. What we know that we do a lot of harm to our patients. So the malignoma itself gives you already side effects because it induces some inflammatory processes and also processes we don't know yet. We might learn from them in our liquid biopsy studies and so on. It depends on how the environmental lifestyle is done parallel to the treatment or before chemotherapy, surgery and radiotherapy, and so on. And for bone sarcoma patients, we know heart, hearing, hormones, kidney, fertility, fatigue syndrome, and what we also discussed in the previous session, especially in the bone sarcoma patients, no one can like walk before, and you might even have like this amputation. And so what's happening, cardiotoxicity is induced by the anthracyclines that we give, and they are very important drugs. We really love them because they cure our patients. And also radiotherapy to the mediastinum can induce cardiomyopathy and coronary heart disease, pericarditis, and valve insufficiency. So you have to watch the heart afterwards. And we know, we do not know nothing. We know that there's a certain cumulative dose that should not be exceeded. We also know that some of our patients do not know their cumulative dose, so if you leave the hospital, you should get any card that tells you, so what have you been given, to know whether there's a risk for cardiotox. And what happens is the heart muscle is destroyed, there are vacuoles, and in the end, cell death that causes a cardiomyopathy and enlarges the heart, and it's not able to contract. What we furthermore know, it's not only the dose, it's also how you give the infusion. In older times, you gave the doxorubicin as a shot. This is not a good idea. It's better to give it over a long period of time. We, however, also don't know whether it might be better to give it like over 6 hours or over 24 hours. There are no studies how to do this right, I have to admit. Radiotherapy we discussed, young age, female sex, time since treatment, and additional cardiac stress are also factors for cardiomyopathy. What is cardiac stress? Cardiac stress is, for example, isometric stress, which is pregnancy. So the doctors should tell the young ladies or the children or the parents, if you have a female child, she should know when in 10 years she becomes hopefully pregnant, someone has to watch her during the pregnancy, and she should deliver possibly better in a larger hospital where if something happens, someone could help her. Also, heavy isometric weight training is a pain for the heart, and also this is something you need to discuss usually more often to the boys than to the ladies, but yes. And from COVID, we all learned that also viral infection, and it's not only COVID, it's almost all viral infection, they can also affect the heart. And even if you did not have the absolute cumulative dose that would put you at risk, you have the flu, you have something else. If the patient feels not good weeks after, you should check the heart, because they could have developed cardiomyopathy. This is very important, and this is what patients need to know. Yeah, because the general physician, they sometimes just don't know about that. Hearing, another story, mostly affecting the osteosarcoma patients. Also, the radiotherapists are culprits here. After a certain dose, we have antibiotics that also add on to the hearing toxicity also later on. So this is also something the people need to know. If you already had platin, you should be lifelong careful with certain types of antibiotics. Yeah, and hearing loss is tolerable if it's only on a certain level, so when it doesn't affect the normal speech language. It might also end up in tinnitus, or the patients exceed like vertigo, which can be very difficult. So recommended is to do an audiogram prior to each platin dose, and the people need to know that they have to or should, whenever possible, avoid additional ototoxic drugs, and some children or young people end up with hearing aids. There was a PanCare consortium. This is a big consortium dealing internationally with long-term follow-up problems in children and young people, and there is already a gene pattern where we know that if you have this gene pattern, you are at higher risk for ototoxicity. The problem is this is expensive to do and not into routine care. Fertility, we will see now I think 6 slides, but I will run through this kind of, also from this PanCare and the International Guidelines Harmonization Group. I was part of it. We all read tons of paper to understand which male person is at risk for infertility. And this is like what we did. So we really read tons of paper. In the end, most of them were of very poor quality. And so we ended up with only very few where we thought, okay, these studies are good enough to be included into the guidelines. And we don't need to read this in detail. So if you have orchiectomy or radiotherapy to your testes, you are infertile. Easy. Also, if you get a high-dose chemotherapy with busulfan, you are infertile. For the rest, we don't know. We don't know. We know that alkylating agents like ifosfamide, cyclophosphamide may cause infertility. We don't know which dose is at risk, who is at risk. It's a pity because we use these drugs since a few years already. Yeah. And same story, same group for female survivors. Also, we read a lot of papers, and in the end, if you have radiotherapy to both ovaries, you are obviously infertile. If you get busulfan high dose, you are infertile. But for the rest, we don't know. Yeah. Then something which is usually also kind of neglected in the clinic is cancer is never experienced alone. And included in the definition of survivors should be the family members, the friends and the caregivers. And the caregivers and friends and families are, for my opinion, the unsung heroes, providing physical and emotional support to the cancer survivors, and they might also have adverse health effects and emotional toll on the caregivers. It turns back to the survivorship. So we also need to watch these people. And this is just, I was last week, this is Leon, he won Paralympics. He got a secondary amputee after osteosarcoma. He's now very happy that he's amputated because he can now do a lot of sports. And we visited him for some survivorship program, and we asked him, so what made the difference for him during his cancer journey? And he said it was only this, the support of my family and friends. It was not the people in the hospital. It was just they always supported me. They were always carrying me, and yeah. So this underlines the quote. Age-adapted long-term follow-up. So the recommendations also from the ASCO community and from the ESMO community is to follow the recommended sex and age-specific routine screenings and tests that you should have. So colonoscopy after 50, mammography after 50, PAPA test, lifetime, and vaccinations and so on. I'm not sure that there's really a completely international standard, but each country obviously possibly has these age-adapted long-term follow-us. The problem is that we also know that chemotherapy causes premature or accelerated aging in both survivors of cancer in adulthood and in childhood. And what we do not really know is how much we need to put all these tests in the earlier lifetime. So for some patients we know, for example, if you had a Hodgkin lymphoma and had irradiation of your mediastinum, you are at risk for breast cancer, and they now get a screening, at least in Germany, after the age of 30, but maybe also other patients would need this. Yeah. And the concern that we have, that is for childhood cancer survivors, that when they are over 45 years old, that there are coexisting conditions that become really life-threatening. And the most of the cancer patients die from recurrence or their cancer, other from second malignancies that also need to be watched. Obviously, this is these testing for other cancers, but cardiac, external, pulmonary, whatever diseases in the later years are really those one who will make problems. And this is an increasing curve because we cure more people. Prevention. Prevention is healthy lifestyle, weight management, physical activity, healthful diet, no smoking, not too much alcohol. And these are examples from our AYA ward in Essen, where we really try to start this already during the treatment. So we have we do cooking together with our patients, and here was a Christmas table tennis tourney like we are doing, so to keep them active even during treatment. And of course, psychology and quality of life is extremely important. So it's very important to offer this. I mean, these are the quotes that we also saw in Sue's image before. So survivors are always afraid whether the cancer will come back. Will I be able to go back to work? Can I take care of my family? Will I get friends? Will I be able to pay my medical bills? Yeah. Will I be able to go back to a normal life, or the normal life I've dreamt before I had cancer? Return up to work is a problem in cancer survivors. Only very few return to work, which is an issue, which is also an issue for all our societies, and I think we need to work on this to enable to make that situation better. Yeah, and only 31% with physical impairment, and these are the bone cancer patients, return back to work. So the idea is to really start thinking of survivorship from the first day the patients enter the hospital. And the ideal world, you would do already a screening then for potential late effects. Is the patient overweight? Are there lifestyle things you should discuss? Is there any screening that could tell, okay, they would get psychological problems? And throughout the treatment also try to be preventive and help the patients to go through this. And post-intervention should also always have all these columns, not only oncological care, but also somatic care, healthy lifestyle, psycho-oncology, and so on. If the time is over, I can finish now. 2 minutes, okay. Um, okay, I just brought some pictures. So we always recommend the young patients to go to a rehab center. Usually our AYA patients don't want to, because it's again a hospital, and I was so long in a hospital and I just want to stay home and with my friends. Everybody who goes to a rehab center is usually afterwards so happy that they did this. So I think I would always recommend this. It really makes a difference, because they do physical, medical, and also psychosocial rehabilitation for their patients. And this is especially important for the bone sarcoma patient, because as we said before, no one gets into that disease as they go out, and whether you get a prosthesis, whether you get a rotation plasty or an amputation. In Germany we have now a broad program, a sports program that is offered in a lot of centers, and we hope to spread this out to other centers. And there's also a European community working together, for example, with Norway and also with Italy and so on, to not only bring physiotherapy but sports, because sports is more the fun part and it's more accepted. And there are studies that showed that you reduce anxiety, depression, you reduce fatigue, the general activity level is better. The body image is better if you do sports. It's a pain prophylaxis and it does immune activation. And so we would recommend to start the sport also during the treatment on the ward, or here's a picture in our outpatient clinic. And we started with our AYA patients, and this is mostly bone sarcoma patient. You can see here with amputees, and these are like patients with after hemipelvectomy who ride monoski. It's a lot of fun, and it really makes an enormous difference for these patients. And if you could click there, this is a little movie for the end. Yeah. Oh, it was funded first by charity organizations. So this network was funded by the German Cancer Aid. However, and it's coordinated in Essen, but the sports people, they do trials. They do randomized trials. They do a lot of trials. And now they did so many trials that they could convince the first insurance companies to pay for it. Yeah, and this is also something. I think we also need to do trials on the impact of art therapy, of sports, and so on, because then you can really prove that it makes a difference. You get the evidence, and this is quite cool. Yeah. Yeah, yeah, we have recommendations, and some of them became because of this PanCare initiative also a bit more evidence based. Um, um, yeah, I can send them to you. For viewings, we have them, but yeah,
We don't have, and I can share with the other patients that
yeah,
show sarcoma and the other,
yeah,
and we want to initiate this the follow-up system in Hungary.
yeah, yeah, no problem.